Good morning to Anandan. Today, I am presenting the impact of multimodal physiotherapy interventions on hyponatramic encephalopathy along with acute severe polyneuropathy. It's a single case study report. My name is Dr. Anandan, MPT PhD, Associate Professor in Madhav University. My co-presenter is Dr. Vinod Kumar Purushothaman, INTI International University, Malaysia. So, introduction. Hyponatramic encephalopathy is a serious condition which dysfunction results from the low sodium levels in the blood. That means hyponatremia. The symptoms includes headaches, nausea, vomiting, and confusions. Other symptoms which includes seizures, respiratory arrest, coma, and brain herniation. The hyponatremic encephalopathy characterized by the symptomatic cerebral edema due to a low osmolar state is a critical medical condition often observed in the ICU. The clinical presentation can range from the mild to severe, with the symptoms reflecting the central nervous system's adaptation to the hyposmolar state. Acute polyneuropathy. It is a form of Guillain-Barré syndrome that is called GBS. It often begins suddenly in the both lower limbs and it progressively rapidly to the upper limbs also. So it predominantly started from the distal to the proximal weakness. So symptoms which includes weakness and with pins and needles sensation or loss of sensation. Respiratory muscles affected in the later stage results in the respiratory failure. Acute severe polyneuropathy characterized by symmetrical ascending type of weakness and sensory changes and potentially impacting breathing and requiring intensive care. The symptoms develop quickly, often over days or weeks, and can worsen rapidly. The most common cause often preceded by a viral or bacterial infection. So, this patient is Mr. X and age is 33 years, sex is male, occupation is a software professional. His chief complaints at the time of admission is presented with altered sensorium, multiple episodes of vomiting, and bilateral lower limb weakness, predominantly in the distal weakness at the time of admission. So, history, he was suddenly developing weakness and altered sensorium. He is a known case of depressive disorder, taking medications for the depressive disorders. He is working in the top software company in India. He suddenly develops these symptoms. Initially, he was treated under neurology specialty hospital in Erode and was in intensive care unit of 3 weeks. It's not a case of diabetic or hypertension or asthma or seizures. So no other comorbidity conditions expect a depressive disorder. Initial investigations including MRI, EEG, ECG showed no abnormalities, while an abdominal ultrasound revealed a fatty liver and EMG and nerve conduction studies indicated that the sensory motor axonal neuropathy. He was shifted to the room once he was stabilized. His GCS was improving in the hospital. At the time of this evaluation, his GCS was eye opening was 4, verbal response is 3, and motor is 5. The patient was managed with 3% sodium chloride solution, and antibiotics and antibiotics and daily serum sodium monitoring. Despite initial stabilization, the patient developed respiratory difficulties, necessitating ICU transfer and ventilator support. The treatment includes anticoagulants, hypertonic saline, steroids, and supportive measures. And also the main treatment for this Ig immunoglobulin is supported. The patient, after 4 weeks of stabilization in the hospital, and the chief neurologist suggests that shift to the rehabilitation unit. So here, the patient was shifted to our physiotherapy center, that is Tulir Physiotherapy and Rehabilitation Center in Erode and Tamil Nadu in India. At Tulir Physiotherapy Center, the patient admitted and was assessed completely by the physiotherapist. Once the assessment was completed, the patient was prepared with the protocols. A team of physiotherapists was deputed for the rehabilitation, and the rehabilitation protocol, basic protocols we are supposed to give is multimodal therapy. That means PNF techniques for the lower limbs and upper limbs, Bobath exercises, sitting training, standing training, balance training, posture education, and gait training. So, first in the multimodal therapy, we give the PNF training for the limbs and trunk. So, PNF technique is the main principle is the autogenic inhibition and reciprocal inhibition. So, the main techniques of PNF is hold relax, contract relax, and hold relax active contraction. So, benefits of the PNF is so nothing but it enhances the strength and coordination of the muscles. So, next technique we give the patient is Bobath exercises. The Bobath exercises, the main entity is mainly used for the neurological conditions. So main principles of Bobath entity Bobath movements is normal movement pattern we have to facilitate and postural control and facilitation and integration of the muscles. So common technique is what are the common these are the common techniques used for NDT, and the benefits of NDT is it improves the motor control and the muscle coordination, and it reduces the spasticity and the muscle stiffness, and also it enhances the quality of movement, and also better posture and balance. So next we are giving is sitting training. Sitting training we are giving, and also next standing training by using the tilting board and the standing frame, fixed standing frame and tilting boards. It's an automatic tilting board, motorized tilting board. The benefits of tilting standing training is it improves the posture and the core strength, and also it enhances the balance, and it increases the circulation. So the standing training and also given by the body weight training and resistance band training. Next, supported standing. Standing with the supported. That means knee locking training. So that means the quadriceps muscle training given. And also balance training in the physio ball. Unbalanced support training with the Swiss ball training be given. And also sit to stand activities with minimal support. And also gait training with physio support, and also patient walking with walker support, and also gait training with minimal support. So now he gaining the unsupported walking and walking training with minimal support of quadruped stick. This video represents the patient initial stage of admission to the time of discharge. So it represents the full recovery phase. And upon 3 months of continuous physiotherapy measures, he becomes the normal and was able to do all his ADL activities. The patient was discharged from Tulir Physiotherapy and Rehabilitation Center, Erode. He was advised to come for another 2 weeks as an OPD management. Conclusion. This case highlights the importance of timely physiotherapy management and multidisciplinary management in a hyponatramic encephalopathy. And despite the complexity of the condition and the risk of neurological complications such as quadriparesis, comprehensive medical care followed by the structured physiotherapy intervention lead to a remarkable recovery. Conclusion. Early involvement of rehabilitation services includes the physiotherapy protocols played a critical role in restoring the patient's functional independence. The patient was completely recovered and joined the duty. Acknowledgement. We also extend our gratitude to the team of Tulir at Tulir Physiotherapy and Rehabilitation Center for their continued commitment to the patient's recovery through the individualized and multidisciplinary rehabilitation. Special thanks to the patient and the family for their cooperation and trust throughout the treatment process. Thank you.